basically, I want to build on what Dr. Agarwal said. So as not to duplicate, he covered the male, I will cover the female. He covered the evidence of the biochemical changes and the methods for detection. So I will cover simply treatment. I will focus on 2 treatments and 2 studies. We have done one, and the other was done by my friend and colleague, Dr. Gardner, who's currently in Melbourne, Australia. So really, again, oxidative stress briefly is an imbalance, as Dr. Agarwal mentioned, between antioxidants and the reactive oxygen species. He's covered the superoxide anion, the hydrogen peroxide, and others. And he elaborated whether these could be exogenous, like smoking, alcohol, pesticide, or endogenous, like, varicocele, leucospermia, and so forth, in addition to psychological issues, as well as age and extremes of exercise. For the populations, there are different things. So for example, if you look at those many issues, you look at in the Middle East, maybe obesity and smoking would be the most prevalent on the right side. And you look in the US, it will be mainly, alcohol and possibly marijuana. I don't think that drugs and so on is prevalent in this particular group of educated patients who are very committed to their treatment. And malnutrition is in terms of imbalance of nutrition, is not in terms of low nutrition, but is definitely imbalance of nutrition. So this imbalance results in a preponderance of the reactive oxygen species in essence. At what level it works, we really are not sure. We think it works on all of them or some of them. And again, Ashok elaborated very nicely on that. I would never attempt to go after him, as he has been actually the pioneer of the meioxis, and we did a lot of work with him through and through Dr. Midhat Amr at Adam in terms of the meioxis in male factor, and we're trying to look in the female. We published that in our very recent book with Dr. Agarwal and with Ed Sabanek, the Vice President of Cleveland Clinic and former chair of urology. That book just came out, and many of our work has been basically been there in great detail. So where does it affect? Whether it affects the egg at an egg level, where it affects the granulosa cells, does it affect the corpus luteum, does it affect the endometrium, the blastocyst development, and so forth? Really, we're not very, very specific, but we think it affects them all one way or another. So again, when you treat it, which aspect would you expect to improve? That's what I'll try and discuss with you briefly this afternoon. Basically, follicularogenesis, yes, it does affect the follicles, and you can see that the follicles have many of the issues that suggest that there is an impact of oxidative stress or reactive oxygen species. For example, the more oxygenated the follicle, the higher the Doppler content has been shown by Professor Campbell to have better quality of eggs. So when there were few number of follicles and few number of eggs, he's demonstrated that doing a Doppler and seeing the one that has better blood supply it is associated with better eggs. The same with there is nitric oxide there, and there are other parameters related to the follicular fluid oxidative stress. Generally, it is less than the serum or the plasma. So it means that there is some level of antioxidant treatment, antioxidants supplements there that does that balance itself. Extreme deficiency on some of the things, like, for example, vitamin C, extreme deficiency on some of the vitamins results in follicular atresia and deterioration in quality of eggs. What about the endometrium? We've done some work on the endometrium, and I would like to summarize it to you in 2 ways. And we actually also published that with Dr. Agarwal again in this book that we published on oxidative stress 6 or 7 years ago. We showed basically 2 things. We showed you that there is a scenario where you have ovarian stimulation, good eggs, pregnancy, and maintenance of progesterone. When the progesterone stays high, which is on the right side here, you get actually an increase in the superoxide dismutase, a decrease in COX-2, a decrease in PGF2, and a maintenance of corpus luteum. When the progesterone drops, like we see all the time in a normal menstrual cycle prior to the next menstruation, then you have also a drop in the superoxide dismutase, an increase in COX-2, an increase in PGF2 alpha. So these are the two scenarios that we see. And there is no question that the HCG plays a good part in that. So when pregnancy happens, what happens? Ovulation happens around the middle of the cycle, then implantation happens, then HCG. The HCG is responsible for the preponderance of progesterone, for the increase in the superoxide dismutase, and the subsequent decreases in COX-2 and PGF2. Whereas when a woman is destined to have her next period coming, then her progesterone drops, the superoxide dismutase drops, some activating factor increases, and the COX-2 as well as the PGF2 alpha increases, resulting in cramping and shedding of the endometrium. A couple of minor words and about endometriosis and PCOS. We think that endometriosis again has an aspect of many things, of course, as you all know, and we had your webinar last week, which was outstanding. I learned a lot from it. But basically, the pro-oxidant factors like heme is not really, iron is not the direct link between endometriosis and reactive oxygen stress, but it's possible that iron is catalyzing some of the reactions of the free radicals. There is definitely a change in the interleukins in the peritoneal fluid and the phagocytes. This was shown by Dr. Badawi from Syracuse, New York, many years ago, where he did some pioneering work on the different interleukins and the different white cell and phagocytes in the peritoneal fluid with endometriosis. So what I'm saying here is that basically that there is an element of oxidative stress in endometriosis. What about PCOS? PCOS is also associated with reactive oxygen species increase, and that is partly because of the high inflammatory state. So there is no question that in PCOS, particularly the scenario that Dr. Hassan Maghrabi mentioned in our discussion session, there is two groups of PCOS. There is the slim PCOS with high LH to FSH with high testosterone, and then there is the obese, could have normal LH to FSH, but would have high insulin and normal glucose, what is known as insulin resistance, or very mildly hyperglycemia. And this is associated with increased fatty acids and increased inflammatory state, no question about that. So there is an increase in all the inflammation markers in PCOS. So again, what is the relation between oxidative stress and fertility? You can damage the egg by the lipid peroxidation, as Dr. Agarwal mentioned, or DNA damage. You can impact the fertilization rate. You can impact the embryo by including the embryo fragmentation. You see, every one of us has seen eggs with looks very brownish granular inside, and we say that there is something wrong there. This is the rough endoplasmic reticulum or whatever is happening. But you can see also that eggs could start normal. And if there is high, particularly high reactive oxygen species or high ORP in those group of patients, there is a deterioration of the embryos between day 3 and day 5. So the embryos do well up till day 3, and then from day 3 to day 5, then you have a deterioration of the embryos, and we have seen that with lack of blastocyst formation. We're all very familiar with hydrosalpinges, and always the question arises, how does the fluid in that fallopian tube, which is a very small amount of fluid, can affect the implantation or cause miscarriage, as has been shown by the Swedish 20 years ago and confirmed by all of us now? It is possibly through also oxidative stress of the hydrosalpingeal fluid. Again, I mentioned the endometrium because when I say that a high COX-2 PGF2 alpha is associated with contraction and cramping of the endometrium and also of early menstruation. What about corpus luteum? Again, corpus luteum is integrated with the system. So basically, we have all those issues, and we'll try to show you studies that looked at those issues one by one, and show you if I have answers for the basic science component that Dr. Agarwal has presented to you in his elegant lecture. Does it affect ART? So this is all those points that I made here, aside the fertilization, etc., affecting the normal pregnancy. What about the ART? And I mentioned to you the work by Professor Campbell, my former mentor from King's College, is that follicles that have poor Doppler flow is associated with poor quality of eggs and so forth. And then there has been these two cartoons from Dr. Agarwal's team in actually a couple of my books. This one was with Professor Salam and Professor Makarigianakis from Greece, showing you that it could affect fertilization, it could affect the cleavage stage embryos as well as blastocyst formation, resulting in a decrease of the proportion of blastocyst, could result in embryo fragmentation at any of those stages, and finally could affect even the cryopreserved thawed cycles. How does it do? I think he elaborated elegantly on the oxidative phosphorylation and the pentose phosphate pathway in his talk, so I will not repeat that. So what are the strategies? What can you do clinically for those patients? And what has been done to show if there is an impact or no impact of antioxidants to protect the oocytes? So there is more data on the sperm side. There is no question about that. Just to mention two of them, he showed you these two studies, one at the Cleveland Clinic on the proteomics, and then the other between the clinic and the Hamad Corporation about the morphology of the sperm and the ROP. If you look at the old studies here, you look at one thing very easily, is that most of those studies are from the 90s. So I'm not criticizing 90s studies. I always quote even my own stuff from the 80s and 90s. But if you look at blastocyst formation rate and so forth, and embryo quality, remember that at that time, we were very scared to put day 3 embryos. For the first decade of my career, we put day 2 embryos. The only reason we put day 2 embryos is we didn't know how to grow them well to day 5. So day 3 was a challenge. I remember our embryologist in 91 showed a presentation in the EFRE of doing day 3 too, and she was eaten alive by the senior audience, some of the world's leading scientists, that it is very dangerous to leave the embryo to day 3 because basically you will get embryo fragmentation. So what I'm saying here is that we didn't have good means of keeping the culture medium to day 5 and 6 and to freeze and so forth, and therefore this will affect the outcome regardless of the neatness, regardless of the elegance of the study. There are studies that show supporting studies that show that antioxidants work. There is studies that showed no effect, and there are studies that show even some bad effects. Like, for example, you can have more ectopic pregnancy and so forth as well. Again, Dr. Agarwal's team published a lot with us. This was Dr. Salam's book, and we did that together about a decade ago. So there has been two approaches. So I'm coming to the end of my philosophical part, and now I'm giving you the data into what is the new evidence, what is in 2020. You can do a clinical study where you supplement by oral antioxidants the women going through IVF for 90 days before the IVF. And then you can do an IVF study where you include antioxidants in the culture medium. My dear colleague, Dr. David Gardner, currently in Melbourne, Australia, as chief scientist of Melbourne IVF, did this study. This is actually my book with David Gardner many years ago, about 8 or 10 years ago, showing you that what he looked at 3 specific antioxidants, at N-acetyl-carnitine, N-acetyl-cysteine, alpha-lipoic acid. He added them to the culture media. And then he looked at what? He looked at the quality of embryo, and I'll specify on day 3. He looked at the blastocyst quality on day 6 or day 5. And he looked at the pregnancy rate in this group of patients. So he studied about 133 patients, a decent number of patients. They had 1,500 eggs, 1,563 metaphase 2 eggs. The study group, they use all the Gardner media to grow the embryos to blastocyst, and they use 3 of them. They use the carnitine, the N-acetyl-cysteine, and lipoic acid. The control group, they use the same media, same group of scientists, same everything up till day 5 or 6 and so forth. And they did not supplement it with the 3 antioxidants as well. What did they look at? On day 3, they looked at the 8 to 10, the number of embryos who have 8 to 10 cells. They looked at blastomeres or equal or unequal blastomeres at the low fragmentation. So they looked at basic parameters that could be done by all of us in any IVF lab. They also looked at the good quality of blastocyst, a minimum of 3 BB or better. The clinical pregnancy rate, they look at clinical pregnancy basically seeing a gestational sac with a fetal pole, rather than seeing ACG. We're not interested in seeing how many had positive ACGs or not. But clinical pregnancy was defined by the gestational sac per embryo transfer and per oocyte recovery. So what the results did David Gardner have in his study? He showed that in day 3 to day 4, they increased the quality of day 3, in day 3, in the G series compared to the antioxidant series, they went from 41% to 50%. So you might say, well, it doesn't really make a difference, but you have to understand that the blastulation rate, for example, the blastocyst formation, is at best 50–60% and so forth when you take all the patients, all the embryos. So to increase from 40 to 50 is a significant increase, not just statistically significant, and I'll show you our data in a minute, but to increase it by 9%, that is basically almost 18% increase or 20% increase of what they were getting. And then he looked at the clinical pregnancy rate, gestational sac, as well as heartbeat. And the gestational sac went up from 40% or 39 to 50, and the cardiac activity went from 37 to 47. And these are the bar charts. The bar charts may show it more easier to you, but here again, 41% to 50%, and again 40 to 50, 37 to 47 in terms of gestational sac, and here in terms of cardiac activity. He then zoomed in on the group of patients that were 35 to 40, because as we both, Dr. Agarwal and I, told you that the aging has an effect like it does on everything. So when you looked at the gestational age, it went from the gestational sac, it looks at from 24 to 57%. And when you looked at the cardiac activity, again, 23.5 to 50%. And then the ongoing pregnancy rate means the ones that didn't miscarry or anything continued, it went also from 25 to 50%, which is a significant increase. This paper was published in RBM Online last month, actually in May the 1st of 2020. So this is very recent evidence. This is in the last 3 months, because we've, there is always people, I mean, like everything else in reproductive medicine in particular, there is team and there is the pro and the con. We just published with Dr. Yaqub Khalaf a book on controversies in assisted reproduction. And I used to say that this was the easiest book to publish, because I could find somebody that is for an idea so strongly and somebody who's against it. So many people think that PGT is the best thing ever, and they would not do IVF without it, and many people would not touch it because they think it harms a certain group and does not carry an overall benefit. But if you look at the increase in the ongoing pregnancy rate, basically more than doubled in his study, particularly in the older age group. And again, this is using the Gardner media versus the Gardner media with the 3 antioxidants, the carnitine and cysteine, as well as the alpha-lipoic acid. And their conclusion was that the presence of antioxidants during IVF for embryo culture for the women between 35 and 40 resulted in a significant increase in the implantation rate, implantation being, like I said, clinical pregnancy, seeing gestational sac, as well as continued pregnancy rate. And they recommended that it increases the viability of the embryos in ART, possibly or through the reduction of oxidative stress. We did this study that is, and again, my fellow Dr. Priyanka Sinha did all the work for us on the study. During a period of time that we had no changes in the IVF lab, except one thing is that we supplemented the patients with antioxidants, as I will show you. Dr. Agarwal has been a guiding force behind this study. Our primary objective was very clear, to look at the clinical pregnancy rate. Again, we are not interested in ACG levels and so forth, although they are useful but limited, per embryo transfer and oocyte recovery. We look at the blastocyst formation and fertilization. Fertilization meaning basically how many 2PN per ICSI of metaphase 2 oocyte. So we currently, not because of scientific reasons, but because of the US practice, that we on all the metaphase 2 and we looked at the number of 2PN, the 16 to 20 hours, and that would be the fertilization rate. When we take that same number, the 2PN, and see how many did blastocyst formation, that would be the blastocyst formation rate. And then when we looked at the clinical pregnancy determined per ET and per oocyte recovery, that will be the final arbitration. The group itself, we started the study in Texas from October 2018, where we supplemented, or we offered every patient, let's say, rather than supplemented, and I'll give you the data, we offered every patient an antioxidants. We compared them with a cohort who were prior to that, because prior to that, use antioxidants at all. Of course, we excluded patients in both groups if they've been taking antioxidants on their own, because we can compare. So if somebody is taking CoQ10, selenium, zinc, whatever they were taking, we had to remove that. We looked at patients between the age of 20 to 40, basically. Of course, all patients were consented, and then we were open to all ethnic backgrounds, which is in Texas means basically a Hispanic population in addition to white population and black population. We excluded the patients with cancer for obvious reasons. So somebody is doing egg banking for cancer and does the IVF later, that we excluded those because maybe there is an impact of cancer on the inflammatory markers. Anybody that had this major surgery in the past month, we excluded them. Significant trauma in the past 3 months, we excluded them. If the patient is taking, for example, has GI problems, severe colitis that affects absorption, as all the medication we did in this study was simply oral medication. We disqualified if somebody started the study but then had major surgery or major trauma, or decided on her own to take other stuff that we did not specify within the study. We screened by now, I mean, so the study was from October the 1st of 2018. Literally, I updated the results up till 2 days ago. We studied almost 400 patients, and more than 120 were specifically 400 potential IVF patients. More than 120 were particularly into the study. We finished the routine medical history. We applied the very basic inclusion-exclusion criteria, and 76 of them were okay to go ahead with the study and obtain consents. But then in the process, some of these dropped because it's very common in the US. They move from one state to another, or they move to another center, and so forth. So this really, we had to get a control group. And as I mentioned, our control group was the same group of patients that we treated. So I've been the medical director and the lab director for that period of time. There has been no changes. The ages were the same, 21 to 40. Again, we opened to any, we did not specify racial group, but we opened to basically groups. And in Texas, that includes a significant proportion of Hispanic patients as well as white patients or Caucasian patients. Again, we excluded from the cohort the same thing: major surgery, accidents, history of cancer, irritable bowel colitis, and so forth, or patients that are on their own are taking concoction of antioxidants or vitamins. We ended up with 100 just over 100 IVF cycle. 51 of them were on the supplementation, 51 were controlled. Some of them had, we do some freeze all embryos, so some of them have not had their embryos. So up till July 15, up till 2 days ago, 33 patients in each arm have completed everything. Completed everything means they had IVF, and whether we froze or not, whether we did PGT or not, they actually had their embryos transferred. And this is the results in the, this is the study group, and this is the control group. The fertilization rate increased from 57 to 63, which is not significant. The blastocyst, and remember blastocyst, I said that the number of blastocysts of good quality divided by the number of 2PN went from 37 to 43. The clinical pregnancy rate, whether singleton or twins, because we do still put 2 embryos in some patients, the majority go for a single embryo, but some patients do 2, went up from a 36.3% pregnancy to 67% pregnancy rate. And this was the only intervention in those 2 years, or just under 2 years, mentioned from October 18 till this period of time. And then, so this is here the fertilization rate, which is the number of N divided by the number of the metaphysics. This is the supplemented group with antioxidants slightly increased, and the blastocyst formation. So you might say, well, the blastocyst formation is not increased much, but I want to tell you that again, that in the best of circumstances, again, if you take all the patients, you will find that the blastocyst formation in the best of circumstances is around here. So do not expect to double that by any measures, but here there was an increase of 6% an absolute increase of 6% from 47 to 43, which relates to a relative increase percent on the 47, which is in the right direction. When you look at the clinical pregnancy rate, it went up from 36% pregnancy rate, which was not bad, to 67% pregnancy rate. And again, this taking all comers as well. So I want to conclude, Mr. Chairman, at this point in time, that this is the evidence that what we have today. This is clinical studies. So basically, these studies add to the significant foundation that was laid by Dr. Agarwal and his team, which is really, he pioneered that area over the last decade and more than decade, that he explained how, and he explained how to measure it. Like you said before that, we didn't know how to measure. And then he explained that you can see that at the level of the basic science as he detailed. About what can you do with the patient. We showed that the supplementation of the patient, whether orally for 90 days or more, or whether by supplementation of the cultural medium has resulted in a significant increase, again, in the pregnancy rate. In our hands, from 36 to 67, and in Dr. Gardner's study, from 24 to 50%. These were particularly marked in this 35 to 40 age group, and I'm analyzing the data. Again, we analyzed the data up to 2 days ago for the purpose of this webinar. This is the evidence that we have in 2020 in both the clinical and the IVF lab. Of course, we need more RCTs, which are difficult to do because, again, you have to tell the patients what data do we have, and we tell them that in our hands that we have seen an increase. So it is very to convince somebody that you should not attempt to use something that we have increased. So we offered it to 100%. That doesn't mean that 100% of patients take it, but we offered it to about 400 IVF patients that I have shown you in this study. But at the end, we have 102 that has completed up to 2 days. And we hope by the end of this year, we have approximately 150, which is 75 in each group rather than that. I want to thank you all for your kindness, for giving me the time, at least the thoughts with you. Hopefully that this stimulates all of us for future studies. And I'm confident that Dr. Hassan Ali might consider our proposal to do an EFRE study with consideration of improving the pregnancy rate even further. And thank you again for this opportunity.